Hi, my name is Ira Kirschenbaum. I am the editor of the Journal for Orthopedic Experience and Innovation. Tonight we have a great presentation, a great group of panelists to discuss the concept of publishing and how to be a publishing all-star. Before we even start, I would like Derek Haas from Avant-Garde, who I think created this brilliant brainchild of an idea, this research all-stars. Just if Derek, if you can give, before we do a introduction of the panelists, if you could just give a little bit of a overview of the project that Avant-Garde took on, and who is Avant-Garde, and why did you take on this project, and what else do you guys do?
Sure, absolutely. Thanks, Ira and Joey, for hosting us today. Really excited for the conversation. So I'm the CEO for Avant-Garde Health, and we're a mission-driven company that grew out of my work with Michael Porter, Bob Kaplan at Harvard Business School, co-leading their healthcare research 9.5 years ago. And we undertook this initiative around the Research All-Stars. Actually, it goes back to an idea that worked on in college actually 20 years ago in my senior thesis, in another context, looking at the impact that Institutional Investor magazine had on its annual ranking of equity research analysts. And to actually turn that article into a case study at HBS back in 2007. And then actually just a couple of years ago, in Slow Management Review, we wrote another article that draws off of this as well, this prior research. And through Avant-Garde, we do a lot of research and publishing ourselves, and wanted to honor all the surgeons who are publishing largely in their spare time, as many of you are, in addition to all the clinical care that you're providing. And so about a year ago, we started working on this analysis to try and identify who are like the surgeons who are publishing the most high quality research on an ongoing basis. And it was a year-long undertaking on our team's part to put together this analysis that we released at the about 3 weeks ago in the beginning of April. And just a couple quick background slides for people who aren't familiar with it. We are publicly honoring the top 5% of surgeons in hospitals and different clinical specialties with respect to the research that they're producing. And in total, we looked at analyzing the data for, roughly speaking, about 90,000 physicians across different surgical specialties. And we were particularly looking at publications over a 2-year time horizon, all publications in PubMed in 2021, 2022. And then we were basically weighting those publications based off of the author position for each of the different authors, first and last, weighted more heavily than middle authors, and also the journal impact factor for where those articles were published. And so basically those three factors, are number of articles, author position, journal impact factor, then went into a composite score to calculate who's in the top 5% of their specialty. And just a couple interesting findings from the research are that the physicians who are in the top 5% for research, interestingly, the patients who are cared for by those physicians, after controlling for a lot of other factors, those patients who are cared for them have on average 5% lower post-discharge complication and mortality rates. And also interestingly, female surgeons are more likely to be all-star surgeons than their male counterparts. Again, after controlling for other factors, female surgeons are about 20% more likely to be research all-stars. And then just like one kind of like stat at the end here is, on average, the people in the top 5% are publishing about 11 articles a year. And I'll save as a cliffhanger for the end of the discussion, if you're interested in within orthopedics, which subspecialties it's easiest or hardest to be an all-star in, I'll share that information at the end of the conversation today. And for background, just in Avant-Garde, we're like an analytics business and help physicians, surgery centers, hospitals to understand how to improve the quality and profitability of their surgical care. So thanks, Ira, for allowing me to provide that introduction for everybody.
Well, thank you. And tonight we're going to introduce all the panelists whose names are not Porter Jones. I'm going to start. I'm just going to mention your name and just tell us. We know who you are, but tell us who you are and where you're from. And JP Warner, maybe you can start.
Yeah, I'm at Mass General Hospital and been there for 26 years. And before that, University of Pittsburgh. And I'm pleased to have a working relationship with Derek and Porter and Avant-Garde. It's been a great journey, and I think what they're doing is really wonderful work. So thanks for inviting me.
Right. Lisa Canada.
Hi, thank you for having me. I'm an orthopedic trauma surgeon, and I really appreciate the opportunity to do this. I am at Novant Health and UNC Charlotte campus, and it's just an honor to be here. And it's great that you pointed out that females have lower complication rates and all that, so I didn't have to say that.
Joe Abboud. Joe.
Yeah, thanks, Ira, for hosting this. Grateful to JP Warner for inviting me to be part of the Avant-Garde study group. Been working with Derek and Porter and the whole team at Avant-Garde, which has been tremendous, really eye-opening research. So thank you for that. And Mike McDonald's down there. I see him now. So looking forward to delving into this further tonight and talking about sort of what Avant-Garde has kind of created with this all-star selection process.
Great. Dan Tobert. Dan, are you on?
Yeah, hi. I'm a spine surgeon also at Mass General Hospital. I've been there for 5 years, so I have about 20% of JP's tenure, but he's obviously a leader in our group. And thank you to Derek for putting together these metrics, the novel idea, and Ira for hosting us.
Appreciate that. Jeff Stambough. Jeff?
Hey, thank you so much for having me. I'm Jeff Stambough. I'm at the University of Arkansas. I'm about 7 years into practice, and I'm a hip and knee surgeon. And I really appreciate, we've worked with Derek and his group on some metrics, so I really appreciate that.
Yes, Paul Sethi.
Hi, Paul Sethi. I'm a sports medicine surgeon in Greenwich, Connecticut. I'm part of a private practice called ONS and part of a larger platform called Spire Orthopaedics. And I'm excited to be on the call too.
Okay, and Kevin Plancher.
Hi, I'm Kevin Plancher. I work in New York City and in Greenwich, Connecticut. I'm the only one with a great tie on. And I'm really happy to be here. And I really thank Avant-Garde for the recognition and joining in the conversation tonight.
Excellent. So let's start. Let's start talking about research pathways and innovations. All right. We could take it, maybe JP, Lisa, and Dan could discuss a bit of the importance of innovation in your research and possibly give us an idea of one breakthrough you're particularly proud of. Maybe Joe, start with you. How important is innovation in how you choose what to research on? Oh, Joe? Hello? Kevin, can you hear me?
I can hear you great, Ira.
I don't know. Maybe we'll go to Lisa. Lisa?
Yeah, thank you for the question. So the question is, how important is innovation in what you did? I'm just going to go back to something I did that took a lot of work. It required, and it was a hot topic at that time. And it was research on using in trauma. It was the first published metric product, and it was using Infuse, which we all know had its own issues. But for me, that was working with a large consortium. I had to get the FDA IDE as a physician, which required a lot of learning, all of that pathway. There wasn't anyone that did that. I had to fill out 125 pages of paperwork and send in twice a year updates. So, when I think about what we want to do, that was a project that got funding from the government in military. It crossed across all kinds of specialties, but by the time we finished, we actually had to stop the study because of the bad effects that came out about PTA, about infuse. So I'm just going to say it wasn't a success, but it taught a lot, and it actually got Metric a lot of funding, and actually started the group with clinical studies.
Excellent. Joe, maybe you can answer a question a little bit too. How does innovation inform your research or some other aspect? What drives your research? Innovation or something else?
I think, you learn from everybody. What I mean by that is people ask questions that are around you, and you're surrounding yourself with people that ask good questions and are excited about trying to answer those questions invigorates me and excites me. And oftentimes studies come from medical students, residents, fellows. It's not necessarily any kind of top-down phenomenon. I can tell you that in 2017, when myself and Luke Austin won the Muir Award, that pain study on pain education came about from our undergraduate student researcher who was trying to get into medical school, asking about the opioid problem. And at the time in 2017, it wasn't the opioid epidemic it is now. It was kind of like, I looked at him curiously, and I remember I was walking around a parking lot thinking to myself, it's an interesting question. I haven't really thought it was a problem. And all of a sudden we did this educational video. So, I mean, I think that surrounding yourself with people that are excited about research excites me. And I think for me, what started this was having a great mentor and Lou Kozlowski and Jerry Williams, and then gradually becoming a mentor. And then all of a sudden, exciting other people. And that really is one of the most exciting aspects of what I do in a profession that I do it.
Excellent. And Dan Tobert, I'm going to ask you a slightly different question, Dan. Why is research so important to you and maybe to the field? It almost seems obvious, but what's the why behind it?
Yeah, I think it's a good question, especially when, as busy clinicians, we find ourselves doing it late at night, on the weekends. I have a young child, so in between her naps. I think that oftentimes it can feel like you get stuck in the weeds, but clinical care, especially in the OR, I think is a real reminder for why we do it. Every single decision that we make is either because of research or the absence of research, and those are the questions that come out of it. And so, to me, I feel like I live in the background of what many researchers created, and part of the motivation to continue that is that I can contribute and be part of that conversation going forward.
JP, maybe you could chime in on the why part, the why.
So mine's a very personal one. Things I'm most proud of, I'll share with you in a moment, but also the mentors are very important. So people like Christian Gerber and Russ Warren are always asking questions, and every single thing that we do that's meaningful starts with the right question. So much of the literature that we read has a question that is not interesting and doesn't change a damn thing. So finding the right question is the beginning. And so my question came when I was a patient in the post-op recovery as a resident, having had an arthroscopy of my shoulder by someone who had no idea what was wrong. And that led to a series of more operations that were not a lot of fun. And so the research that I ultimately did some years later, maybe 10 years later, won the Young Investigator Kappa Delta Award for understanding the normal and abnormal factors that affect stability and instability of the shoulder. So that was a personal journey that took me from a spica cast to a Kappa Delta Award. And I felt that I contributed something, and I think it redefined what we understand about shoulder instability. Since then, there have been lots of other things, but having the feeling that you answer an important question, not just for yourself, but for others, that prevent them from going through what you went through, that has a lot of meaning.
I'm going to switch to another slight area and go to Kevin. Kevin, I know you're in a busy private practice and you run not a small course, but a big course. How? We talked about why. How do you get research done in your environment? because we have a lot of people going to listen to this recording. They're in private practice. They want to do some research. They're in academic practice. They want to get going. And I'm going to ask all of the panelists how they set up their research effort, because I think that's a big unknown area for people who are new in research, who want to get better and want to get from the 95th percent to the 5%.
So you're sticking me with the how. I'll deal with it. I'll answer the question. So I may be the albatross. I started in academics, and I saw in the Bronx and Montefiore a lot of things that surprised me. And so I had to figure a mechanism. When I went into privatemics or private practice, there was no one to help me. So I knew that it had to be, first of all, from 10 p.m. to 2 a.m. Outside of the workdays. So you have to make that sacrifice. And then I chose to find some researchers or people that had PhDs, and we formed a foundation, a 501c3, to help me because I didn't have the academic institution of Albert Einstein anymore. And so the how was finding people. And one of the places I did my fellowship, like the other ladies and gentlemen said, had a structure of a group of people that get together and help you to write after you think of the ideas. So the how is there are companies now that go out and can help you if you're a private practitioner to tabulate your studies. And so you don't have to be in academics, and they really do a great job. So anyone who's in private practice can do this. And my mentor said you have to track people from day one. So I encourage you to do that and see if what you think is you're as good as you think you are. And sometimes you get really something slammed in your face to realize, oh my gosh, I didn't realize that. And there's nothing worse than follow-up. I mean, 20-year follow-up, 15-year follow-up. I don't care about 2-year follow-up. And so you really get to learn something. The how, hire someone that cares about you to help you to write up the things that happen with your, for me, patient experience, because I wasn't in an institution. So I wasn't concerned with the bench research that some of my colleagues would do. I wanted to track patients so the community can know we can make a difference in certain areas.
Excellent. I'm going to push this on Paul now too, who's also in a private practice but has remained incredibly academic. Paul, what's the how in your kind of scenario?
So for me, it's a little different. I don't have the resource. I don't have a ton of people. And now later in practice, I have the privilege to work with Kevin's fellows and the like. But I took this in chunks. I would identify a problem I'm having. And if I was having that problem, I would assume that other people are having it. So whether I didn't, when it first came to the distal biceps, you could walk on a post-op ACL, but it didn't make sense to me that you couldn't move your elbow after a post-op distal biceps. So I said, look, this has got to be fixed. And I devised a way of fixing it, right? And then I didn't understand why we're getting so much P. acnes. So I went and said, look, let me see if I can put benzoyl peroxide on it. So I took chunks and small things. So instead of following a series of 200 or 300 patients a year for 10 or 15 years, which I didn't necessarily have the bandwidth to do when I first started, I said, let me try and fight things that really matter to me in my clinical practice. And it subsequently led to a machine and people who are interested in helping me. And there have been many along the way, but it was small chunks and bites and small fights.
Excellent. I mean, I think that's an important lesson. Jeff, I'm going to ask you sort of to take us a little different way. How do you personally, Jeff Stambough, how do you personally identify topics of interest in your, in an academic setting for both the academic community and possibly for community impact? So how do you identify these topics, Jeff?
Yeah, I think the topic identification is just with what you're seeing in the clinical setting. So we're a tertiary referral center. I chose an academic practice in an underserved state for kind of a reason, because I wanted to take care of complex things and address complex problems. So we are inundated with, I do joint replacements, so we're inundated with infections, multiple fractures, periprosthetics, and things like that. So identifying a focused problem like others have come up with based on what you're seeing on a daily basis. So we've gotten involved in large scale research consortiums to look at paraprosthetic databases. So combining your efforts, right? Because if you're going to make a difference and you need enough patients with certain complex problems, we've learned to partner with other institutions and other like-minded individuals who are interested in the same, taking care of the same complex problems. So I've been able to successfully make connections and work with people that I've trained with in residency and fellowship and along the way. And those connections that you make at the local meetings, on the interview trail when 10 years ago, those have paid dividends. So keeping that Rolodex open and reaching out to like-minded individuals taking care of similar issues is how you can collect data and do multi-center type work to answer these larger questions.
Did you really say Rolodex? I mean, you have to define that for everybody.
Right, just on your cell phone, whatever that VCF is.
I didn't know you're that old, Jeffrey.
What I learned is right now is that if you have a difficult revision, you send it to the south to either Herrick Siegel or Jeff Stambough.
Yeah.
If the state starts with an A, it's in the south. That's where the disasteroplasties seem to end up. That's where the research is.
It's gravitational pull. So.
There's a gravitational pull. I get it. It's really good. Joe, I'm going to ask you a kind of different questions. Where do you think the future of orthopedic research is going? Is it going to try to answer public policy questions? Is it going to answer? Where do you think most of the trends are going now, Joe Abboud?
Yeah, I mean that's a difficult question. Probably very biased based on where I practice. I think access to care. I think physician burnout. Physician overall bureaucracy and amount of paperwork we have to do relative to patients that we take care of in Philadelphia County. It's extremely litigious. So I think that depending on what county you work in, that also is something that advocacy is a big aspect of concerns personally for me. As far as shoulder, I think that continuing with AR, MR, robotics, we're seeing robots starting to get some releases in the shoulder world. We'll probably see 2 by the end of this year. So that's an exciting area of research and study. And we're seeing numerous IDEs looking at stemless reverse shoulder arthroplasty. But, being a shoulder surgeon is a very exciting time. The amount of innovation in the last 20 years of my career has just been unbelievable. I don't follow the hip and knee literature or foot and ankle literature that closely, but I think we trump those sort of extremities, but maybe I'm wrong as far as the amount of innovation we've had in the last 20 years.
That's very interesting.
Hey, Ira.
Yeah, Kevin, go ahead.
There are 2 sides of unknown advantages or disadvantages of doing research I wanted to share with the young people. So, one, if you pick a topic that is, I call it a dwarf disease or something, beware if you write about something, because you will now be the expert and everything like that will come into your practice. And so I wrote something on posterior shoulder once, whatever, and I got some crazy people that came in life. So you just have to be aware. But the other good side is if you really endeavor as a young person to write some reviews or research, when or if a patient comes in, it turned out that was my second opinion. And people said, well, you've written about it and you see this, and they knew. And then second opinions didn't come. So for a young person that battles maybe, or it did for me, so many smarter people and so many people to get other opinions, it went away. And suddenly they said, well, I'm going to go with you, Dr. Plancher, because you wrote about that. Whether that's good or bad, it's just another facet of how research can help your practice and increase actually your income.
Lisa, I'm going to wonder, I talked to you about the idea of researching classically academic topics, access, disparity. how difficult is that type of research versus taking your first 100 femur fractures in the certain trauma center? What's the difference between those types of research for you?
So there it definitely is a difference. The trauma, and one thing I learned just for everyone that's on this call, so that we're teaching them in trauma, it's best to do lots of multi-center studies because you're going to have the number. Not everyone has, there's power in numbers by combining forces, but you asked about the non-clinical, and I was going to talk when Joe was saying, some of the topics, important topics that we're seeing coming up are AI, social determinants of health, and diversity. We just received, I was on a call 2 hours ago, and it will be announced. Zimmer Biomed is funding $150,000 to go to work with the Ruth Jackson Orthopedic Society on diversity and gender-related injuries, gender-related topics. So you have to define the problem. It's a little harder to do soft research in where there isn't a definite answer. The one thing I was going to, social determinants of health, it goes across every specialty, no matter what specialty you're in. And Epic actually makes it easier, or an electronic medical record makes it easier to identify those areas. So before you go in, you have to be very organized, have a specific problem, and have a specific way that you're going to obtain the answers you want. Start small. Maybe do it even as a quality study and then get bigger. One thing we looked at was elbow dislocations in our emergency room, and trying to look at how race and language barriers affect that. So pick a problem, start small, find a way to get your answers and combine forces. But I think that is an important topic across all specialties. Gender diversity issues are also across all specialties. And, part of most organizations' mission statements now.
So I'm gonna put both JP and Dan on the hot seat just a little bit because you guys are at Mass General, which is part of course, the Community College of Cambridge system, otherwise known as Harvard. How important is it to look at the location of where the research is being done? In other words, the results of spine surgery at Mass General versus the results of spine surgery at where I work, Bronx Chair Health System, which is a poor congressional. How important is location or where you get your results? It's ubiquitous and applies everywhere. What do you think about that? Let's start with maybe JP.
Well, there are two things I want to comment on. One is that there's confirmation bias infused into most studies anyway, and mitigating that is a big problem. If you talk to Mo Bandari, who's the world's expert on evidence-based medicine, 75% of all the cohort level 4 studies that are done are ultimately proven wrong by the exact same study done by someone else. So it's very important where these things are done. But more importantly, I want to just comment on something that I've thought about now, and I just submitted an IRB on, and that is looking at the culture of an organization and your ability to do certain types of research and get things done. I mean, how many of you in this call have ever been frustrated dealing with an IRB or dealing with your environment in terms of the silos that exist within the organization and the problem you have to collaborate with individuals? These are barriers that are put up by major academic medical centers that purportedly are bastions of research. And so we're starting a study with a collaboration with Harvard Business School looking at the impact of culture and people's perception of the culture on their ability to actually answer questions that are important to answer. And we're using Clayton Christensen's principles, which hasn't been done before. Because if it's one thing that I found in my career, it's been the huge frustration of trying to get things off the ground is very much dependent on where you're doing things. And I've seen many colleagues that work in places where there's not as much friction, and they're able to get things done much more easily than I feel I can.
Okay, Dan?
Well, I'd agree with JP. I mean, the friction is a real issue, especially as big healthcare systems continue to consolidate. I think there's a couple things to add as well, which is the location of where things are done is important, but there are a few things that I think over time are leveling the playing field. One, outcome measures are somewhat generalizable, but are being collected across the country. And so there is clinical outcome measures potentially that are going to be much more ubiquitous. And so we're going to be able to compare what were apples and oranges. So that's good, I think, going to be very beneficial moving forward. The second thing is that since the ACA was passed in 2013 and required electronic medical record implementation, there's been reams and reams of data collected by essentially every healthcare system, the biggest EMR being Epic. But what's now happening is that there are lakes and lakes of data that over time will become collated, synthesized, and we'll be able to know much more granular information about people. So I think over time, those, if you call them lumps and bumps of differences, are going to become smoother.
Very interesting. I think, Jeff, at your institution, what kind of institutional support do you receive, and how much does institutional support drive the volume of research you're able to do? Or is it really originating from the soul of the surgeon and versus the institutional support? Because you're at an academic center, Jeff.
Yeah, no, that's a good question. I think it's definitely multifaceted, and I don't want to downplay or speak bad about my institution, but this is research is, certain centers, Mayo, Hopkins, things like that, research is embedded in that. NIH dollars are embedded. And I trained at a facility in St. Louis that had a ton of NIH dollars. So I kind of learned how to play that game and how the process works in terms of generating funding and linking up with NIH research grants, because that benefits the institution, not only you, and to do your research. So there's dual benefits there. But from an institutional standpoint, especially as we get into a cost-conscious era of medicine, that their bottom line matters too, even in an academic center. So, I don't have protected time for research. Research is like others have spoken on, is something that I enjoy doing, and we recruit medical students to do, but the research support I get institutionally, they do help us with research coordinators. And we actually have some links, being a university through a state-run institution, to like the Department of Health. So we have people that we can share time with in our department who have dual positions and dual appointments, which has been helpful to do some broad-based cost-based research, some epidemiologic research as well. So those are the levels of support that we do get, that we can take advantage of, and you just have to look for those avenues. And again, that takes it back to the original questions of what are the important things here in research right now. And to echo what others have said, with innovation, I think cost and the delivery of care is another thing that some of the medical students and residents who are on here right now can think about when looking for projects and to come up with ideas. Is there's a lot of database studies out right now. There's databases, private databases, Medicare databases, registry databases, et cetera. But looking if you can get something and get your hands on things that have cost-based data, that is going to be something that's very big in the next 10 plus years as medicine starts penny pinching.
Great. By the way, if anyone has questions, of course, you can put them in the chat. I encourage them. We will call on you personally to ask those questions. I want to talk about one word, proxy. Okay. And Derek had a slide about this, that maybe research is possible is a proxy for quality. So I'm going to kind of go around to everybody on this and ask their opinion, maybe 30 seconds, a minute, whatever you want to talk about. And I'll start with Dr. Paul Sethi. I'm not going to ask you whether is research a volume and quality a proxy for a research and volume of it a proxy for quality surgeons, but do you think the public perceives that as a proxy? Jeff?
I mean, I don't know. I don't know. Look, it's a sort of self-fulfilling prophecy for me to be on this call and suddenly say I do research and therefore I have quality. So I take issue with believing that myself. perhaps it's the individual who's interested in research is just that much more interested in their craft and their profession. And maybe that's really the reality of it. But you got to be really careful. And I don't know that, unlike Kevin's patients who are smarter, more sophisticated, I don't think my patients know that I go down to whatever meeting, wherever it is, and gave 4 talks in Australia and jetted back. The people who know that are my kids and my wife, who wonder where the heck I went. So I do it because I love it, because I'm curious, and because it's my own internal pathology. I'd like to think it's a proxy, but I'm not convinced. But let's see what the real academics say.
Okay, let's go around the room with everyone I see here. I'll start with JP.
So I want to give credit to Christian Gerber, who put it very clearly. And if anybody wants to, delve deeper into this, there was a wonderful talk that he gave at the 2023 Codman Shoulder Society meeting on innovation. He and Lanny Johnson were talking about innovation and entrepreneurism. And what he said was that knowledge is the enemy of innovation. And so we believe that what we know is the truth, but about 50% ultimately is proven to be wrong. So if you really want to innovate, you need to find out what of what you know is wrong and prove that something else is different or better. And if you do that, then people will change how they do things. And that will ultimately benefit individuals. That includes the way you measure things. It includes the way you look at things. So I think at the end of the day, the most important thing that I've seen in the great innovators, be it Paul Grammont or others, is that they had the courage to question the status quo and to find what was wrong in what they knew and completely change the paradigm of care. That's the basis for the Dominic Meyer Award, which is given every several years. It's basically a Nobel in orthopedics, and it's rewarded people like Reinhold Gans, who thought of hip preservation and made that into a whole area that really changed patients' lives. That's kind of why you do innovation and why you think about these things, in my opinion.
Mm-hmm. Jeff, the idea of quality.
Yeah, I think quality drives everything we do. As we said, it's about the patient and the outcomes, and anyone who's taking care of patients with complex problems, you want them to do the best you can. And I think quality drives all these questions in terms of how can we treat patients better. Things you learn in residency and medical school. You start scratching your head, and I tell our fellow and senior residents is, you come through our rotations and you look at things and you say, hey, I like the way you do this. I like the way you think about this, but you should amalgamate that with, how others think about things, and you should go elsewhere to get those ideas and grow your mindset. So that quality in terms of delivering patient care, I think that leads to all of our research questions and to focus on the larger scale problems.
Dan, I'm going to switch gears a little bit and ask you about what do you feel the barriers that you've come across from the beginning of you beginning research to now, barriers to start and continue research. What are some of the barriers that some of us are going to have?
I think what JP mentioned about the IRB is true. I think there are a number of friction points at big institutions. I think that there's ways to get so-called umbrella IRBs to try and get around some of that. I think the kind of research I focus on is using large-scale data sets, and so I've tried to spend the time to learn coding languages like Python and SQL. I think we're all, on this call quite intelligent enough to learn those things, but time is the ultimate currency. And most of us don't have time as busy surgeons to learn how to code things and abstract data. And so one of the things that the barriers is finding people that understand those languages and understand clinically what the questions we're trying to ask so we can get the answers. But there are people out there that exist like that, and that's really something that can be overcome.
Yeah. Anyone else want to chip in on some barriers? Kevin, some barriers?
I wanted to first add in the quality. I'm sorry, and then I'll do barrier. Don't underestimate Dr. Sethi and his self-deprecation. So I think that I learned from Henry Mencken a long time ago. There was dogma. It's always in medicine. And I think I enjoyed always thinking about a question that would tear down dogma. Why do we do it? And they would say, because. And I would say, not. And so when I was a younger man, I was trained something in Boston, came to New York, and I got a letter from one of the chairs, very powerful man, who said, if you ever do that procedure again in New York, we're going to railroad you out of New York City. And then I decided to start publishing on all that material. So you got to go against the grain. So the barrier, I think, is you got to have the guts to do it. And if you do it in science and in research, then suddenly it can quiet those opinions that maybe are making money for other reasons and it's not based on science.
I have another question. I'll throw this one over to Joe Abboud. I always love it when you guys don't know what questions coming your way. When you read papers in your specialty, how many issues does it take you before you come across an article that really changes the way you practice? In other words, how much good research is laying out there and how much is just being plopped around? Joe?
Well, I mean, research, the number of research publications has skyrocketed, and the number of journals has skyrocketed, the number that are indexed has skyrocketed, and the fees that they ask you for some of these journals is skyrocketed as well. So I would say garbage in, garbage out a lot of times. I think sometimes the ideas are interesting, but there's definitely underpowered issues. There's bias issues. But, I think I like to peruse generally JSES, the Arthroscopy Journal, AOSSM, the JBJS. Those are kind of my go-to first kind of tier. And then I'll occasionally look at, this is for Lisa, Journal of Orthopedic Trauma, see what they're doing. So I look at all the various journals, I leaf through them, see what kind of interesting things there are out there. It's enlightening in some ways, but occasionally I would say maybe once every 2 months, I'll read an article. I go, okay, that's practice changing in some ways, but not often. And I just think that a lot of people are doing iterative work that's important, that is eventually validating or helping us understand something better. But there's not many papers that are like, earth shattering. You're like, oh my gosh, I can't believe this. This is unbelievable.
Lisa, what are your thoughts on that?
So I tend to agree, but I peruse a lot of journals, and one thing I do to not only to keep on top of things, but also to come up with research ideas is I looked at recently the Academy. I looked at every specialty day program to see what everyone's talking about in their specialty. I look at the programs for other specialty societies to see what is hot and what isn't. And I also have learned over time that there are some articles, even though database studies, I mean, everyone has their own opinion on that, but sometimes the data that comes out of that is really something that you need to talk to your patients about and tell them. And for example, for me, the geriatric population I'm taking care of, the periprosthetics and the death rate and mortality rate, and then, infection rate, what happens if they get an infection, that's really important. And also DVT prophylaxis can be practice changing. We've changed from all the big drugs to aspirin's fine for everything practically. And those are practice changing, I think. But it's about once every 2 months, but I really try to stay active in every meeting I go to. I do go in the other sessions, not just stay in trauma, so that I can learn research practices, learn different databases to evaluate, learn different ways to report things. And I always say, question everything every day. And then if you don't have the answer and you can't find the answer, that can lead to more research.
Ira, can I just make a comment here?
Go for it.
It would be remiss of me not to mention the work that Avant-Garde is doing in this research study group we have for value-based care, where we look at huge data sets. And those huge data sets give very, very compelling evidence as to what really matters. So it's not so much a question of which journals you read or whatever. It's a question for whose work are you looking at and where is it coming from? European Society, Arthroscopy Society does the studies that include thousands of patients, and the impact of those studies are significant and difficult to argue with because of the sheer number. So many studies are fragile in the way that they're created because the numbers are too small. So study structure and who's doing it is really critical. And registries, the Australian Registry of Arthroplasty is incredibly impactful from the standpoint of looking at things like cross-linked polyethylene and et cetera, that people argue about, but it's hard to argue with enormous data sets and registries that show a significant difference between one group and another group. So for me, that kind of elevates the bar rather than it's in this journal or that journal, because, you know, if you look at the research that comes out, I don't know if anybody here knows what the incidence of publication is of papers presented at the American Academy of Orthopedic Surgeons. What percent of those papers actually get published? I may be wrong, but I heard it's around 15 to 20%, which means we're watching a lot of things that can't even get through peer review into publication. And so how you look for things is critical. And there's no question in the short term, AI is going to be telling us what we're looking for. So we don't have to spend so much time hunting through and sifting through all of this material to come up with things that are really important evidence.
Any other comments on that before I continue? Let's talk just a little bit where, as most of these topic sessions go, we run out of time before we even blink an eye. You know, it's like we could have, Joe would have had 2 reverse shoulders done by now and out of the OR at the Rothman Institute in this time period. So let's talk about speed to publication. Is it is it an issue now? Is it still an issue? It used to always be an issue. You know, you put in your paper on January 1st, 2024. When do you expect it to be published, and when does it really get published? All right, because that impacts the idea of innovation coming out. All right, so let's take this around. Maybe we'll start with Dan again, Dan Tobert. Speed to publication, is it an issue or not an issue?
I think it's an issue, and I think it's pretty all over the place based on the journal. And I think that there are a few things I can comment on. One, in full disclosure, I'm a deputy editor at Spine, and there's been some new leadership there over the past 2 or 3 years. And there's been an effort to really get papers out on a timely basis. So we try to get a peer review back within 3 or 4 weeks, so that there's a decision. So on January 1st, you have a decision by the end of the month, and you're either resubmitting somewhere else, or you're getting a revise and resubmit. But I agree. I mean, it's an issue, because if you get a reject and a second reject, next thing you know, it's January 1st of the following year, and that data is now old. So I think somebody else mentioned the outrageous fees that were being charged to do this research, and I think that's a real point. We're being charged a lot of money to sit around with a lot of the work that we've done. So I would say certainly it's an issue.
Yeah, let's combine those 2 issues: speed to publication and article processing costs. Some opinions about both of those. Jeff, Paul, go ahead.
Yeah, I'll jump in at this. You know, the peer review process is so broken. The reviewers sometimes are not knowledgeable enough. I remember I sent an article on opiate minimization, and the reviewer told me this is an American paternal problem, and we were not writing about relevant topics. The idea that, you know, you get an article kicked to the open journal, I have to pay you know, $1,200. I mean, I have to pay someone money to give them my IP and share it. It's dysfunctional, it's broken. And look, as you didn't ask me, this isn't a lob to you, but it's a pitch to you. Like, look, your journal allows us to have a peer-reviewed process that can happen in an open access way. And the idea of producing research, at least for me, is so that other people can see what I can do, not so that I have to pay. I'm not an institution. I don't get all my journals for free. I pay for every one of them. So I want to get what I write to be reviewed, to be vetted, to be thoughtful, but then I want everyone to have access to it.
Yeah, I think that's right. Some other opinions on the article. I mean, this is like a JOEI advertisement. You know, we don't charge article processing cost to anybody. And I think that's a model that should be at least every specialty should have a journal that does that. Nature, as you know, charges as much as $12,000 for article processing costs. That's actually remarkable. But Jeff, have you found the peer review process and the article processing costs somewhat harrowing?
Yeah, it definitely is, especially if your first pitch journal doesn't work out. So every subspecialty kind of has their go-to niche that they look for. And once you say your paper doesn't quite make that cut, falling in line after that, it can be difficult and be costly. So, and then oftentimes there's, secondary benefit, like they've said, of the added costs of, if you roll it over to this journal, you can, it's already been peer reviewed, so you can get fast tracked, but then you got to pay X amount of dollars to it. So the monetization of research is something that I don't see ending, unfortunately, but I don't have a great answer to that. I would say for the people on the call is focus on journals that produce high quality research, and that, the turnaround times are quick, right? So some journals turn around in 30 days with a review. Some take, 6+ months to review a paper. And as you said, that's just not tenable.
Yeah, good. I'm going to go around. We have about 4 or 5 minutes left, and I'm just going to have some overall final thoughts about the world of research. Anything you want to say about any aspect of research? And I will start with Kevin Plancher this time.
Oh my gosh.
Hello,
Start
Tom.
young, track every patient. It could be a single page prom. And then when you're 20 years and 25 years out, it's so rewarding. See your patients back. OREF can help you as well. That's why Ortho Summit's teaming up with them this year. Stick to it so it judges you. You'll be all of you, a technical surgeon, but can you look back and see how rewarding it is that you changed people's lives, so that you really know that you improve your skill set every day? And I think it's a lot of fun, and you need to find someone that enjoys that with you. And so find someone to do it. I think it's probably one of the most rewarding things. And I thank Avantgarde, as JP did, for recognizing this. And I hope young people will still do it, private practice or academics.
All right, Lisa, some final comments.
So I have to say I have the best PhD statistician. I've worked with her for 15 years. She's on numerous papers and is a full professor now because of all of that. Surround yourself with good people. In every research that you start, I really follow up and finish it. Don't start something without finishing it. Think of all the work that went into it and all the IRB people. Think of everyone that went into approving this, and then how many lives you can change when you publish it. So really, I encourage everyone to follow through on what you do and get people involved, build your team, and build your reputation that way.
Superb. JP, some final comments?
Yeah, I'd agree here. I think it's important to understand this is a team approach, and actually the best experiences I've ever had is when I've been in a room where everybody in that room was smarter than me. The worst were when I felt like I was the smartest person in the room. So the message there is surround yourself with people that give diversity and thought, and that results always in a better product and more influence in terms of what you do. Spend a lot of time thinking about the question before you start to look for the answers.
Jeff, some final comments?
Yeah, and I think I'll echo a lot of the sentiments that have been said, is just surround yourself with people who are interested in similar topics and bring out the best in you. So having partners who are interested in doing research as well helps you, exponentially. So you can't, no one man or one woman can do this on their own. You need a whole team, and bring people along. Like, part of research is training and inspiring the next generation. So I was lucky enough to have researchers when I was in residency who I could team up with and brought me along. And now I'm trying to give that back. So always look to bring on medical students and residents and build them up as well.
Okay, Paul?
I think you should stay curious really pursue topics that you're passionate and interested in, because that'll give you the wherewithal to get to the end.
And Joe, you want to bring us home for tonight? Joe,
Yeah, no, I think the everyone who's on this call knows you catch the research bug, and it is, it's addictive, right? It's so fun when you complete your first project and you see a manuscript, and you just catch it. And once you catch it, it's it's with you. It is like Kevin was saying. I was in purely private practice when I started. My mentor told me collect data on everybody. I applied for an ORAF Career Development Award, which was $100,000 at that time, a basic science study. I was able to pay the indirect fees to University of Pennsylvania so I could do the study in their lab with Lou Zaslowski. And from there, I just sort of caught the bug, and it's just very exciting. It's very fun. Find a mentor that's, matches your energy and excitement. Find a finisher, and I guarantee it'll be an important aspect of your career in this profession.
that's superb. I want to thank Derek Haas, Porter Jones, Avant-Garde for helping us put this on tonight. So I want to thank everybody. And
Ira, wasn't Derek going to give us a punchline or something about?
Yeah.
Let Derek tell us which specialty is the one
oh
that.
yes, that's right, Derek.
Right?
Yeah. So I'll just say Joe is onto something comment he made earlier about the amount of innovation in shoulder and elbow space for the last 20 years. So out of the different subspecialties in orthopedics, shoulder and elbow was the highest bar to get into the top 5%. So on average, in top 5%, shoulder elbow surgeons produced 16 articles a year over those 2 years. And the lowest bar was hand and wrist. On average, they produced 7 articles a year over those 2 years.
Wow.
Ira, can I say one thing?
Yeah.
Join Joey and Paul and Joe at Shoulder 360 next week.
All right.
I've been saving
Thanks,
this
Mike.
hat.
Appreciate
I've been
the
saving
plug.
this hat all year to do that.
And
Hopefully they give new hats again.
also just wanted to, again, congratulate, and thank all the panelists for your fantastic research. Anybody else that's on that's, also being audited as a research all-star. And, really grateful and appreciative for all the fantastic research you're contributing to improve everybody's care. So thank you for doing that.
It's great stuff. Well, thanks everybody, and I appreciate it, and everyone have a great night.